Hello friends, welcome to another session of Video Shots, and today we'll be talking about a rare but a very interesting case from genitourinary imaging. So this is a case of an 87-year-old male came to us with hematuria. When we did the sonography, the prostate was huge. It weighed around 114 cc. But there was something else which was either causing the bleeding or was a part of the bleeding process. So this is the transabdominal scan, and what I focused is the right kidney. I want you to have a look at the right kidney and tell me whether you can pick out anything which may be the cause of bleed in this case. So when you look at this particular sonography, I hope everybody of you would be able to conclude that there is something which is seen filling the calyces as well as it is extending in the renal pelvis. Let me play this video again. So what do we see here? We see that there is an echogenic structure which is seen filling the lumen of the renal pelvis. It is also seen extending into the calyceal apparatus. And when we do the color Doppler scan, we can see that primarily the lesion is not showing any significant color flow. Here we can see that it is clearly showing an interface with the adjoining clear urine in the calyceal apparatus. One more important observation is the dilatation of the calyceal system as well. So we do have a hydroechoic intraluminal structure within the renal pelvis and the calyceal system, which is not showing significant color flow. We have only two differentials. First is we're dealing with a clot because the patient is bleeding. So obviously it might be a clot which has lodged itself inside the renal pelvis and the calyceal system. Or the second more dreadful thing that we can think about is some form of a malignancy. So what do we do now? The next step to be taken is a CT scan. But before we go ahead and talk about the CT scan, let's have a look at what we found on the IVU images. On the IVU images, the left kidney shows some dilatation of the renal pelvis. Actually, this patient had a left-sided pubescent stenosis as well, which is quite well seen on this IVP image. But apart from that, if we look at this particular kidney, we can see the contrast in the ureter. We can see the contrast in the lower calyces and the middle calyx, but the upper part of the kidney calyceal system, that is the upper calyx and some part of the middle calyx, is actually not showing opacification. In fact, it's showing some amount of stippled appearance because of extravasation, or you can say entrapment of the contrast within the calyceal apparatus. This type of a sign is also called as a steeple sign, which refers to this abnormal steepled heterogeneous appearance of the calyceal apparatus because of something which is filling the lumen of the calyx. What is the finding now? We do have something which is located in the calyx, which we could see on the sonography as well. And this is the reason why I don't really like IVP anymore, because clot can also produce this type of an appearance, and any renal malignancy can also produce this type of an appearance. What do we do now? We do a CT, and this is what we got on the CT. On the CT, this is the axial non-contrast image, and this is the post-contrast image. I hope everybody of you would be able to see that there is something which is filling the lumen of the renal pelvis and the calyceal system, and this is clearly showing enhancement on post-contrast study. A clot is not likely to produce enhancement. A clot would be hyperdense on plain scans, but would not show any enhancement on contrast administration. So I put the three images in the coronal view, one over the other, for your easy understanding. This is the non-contrast image where you can see that this lesion is typically seen filling the renal pelvis. It is hanging inside the renal pelvis and is also extending in the upper calyx and is showing very significant enhancement. One other important observation that you can make is dilation of this calyces in which it is filling. The upper calyx appears to be dilated. So if you see a dilated calyx which is filled of any tumor, then you call it as oncocalyx. We have an oncocalyx here, and on this excretory image or your delayed scan, you can clearly see that this particular tissue is standing as a filling defect and is seen very well separate, forming an interface with the adjoining calyceal system, and it is likely to represent a malignancy. So when we talk about malignancy, we obviously are faced with two different options. Either we're dealing with some form of an RCC, or we're dealing with some form of a urothelial malignancy. Now, urothelial malignancy means we're dealing with some form of a TCC, and an alternative name for TCC now is urothelial cell carcinoma. So what do you think? Are we dealing with an RCC or are we dealing with a TCC? In this particular image, you can see that this lesion is predominantly centered within the calyceal apparatus. It is not extending within the renal parenchymal tissue. RCC would start from the renal parenchyma and then it would invade into the calyceal apparatus. Secondly, look at the shape of the kidney. The shape of the kidney is very well maintained. it means this lesion is actually not growing inside the renal capsule. It's not going inside the renal parenchyma, not distorting it. This type of growth of the tumor, if you remember, is called as a bean-shaped growth of the tumor. While RCCs are typically ball-shaped tumors, which are not only having an extension within the renal parenchymal tissue, but also having an extension of the exophytic part. Either the tumor is going to be present here, or the tumor is going to be present here, or the tumor would be completely endophytic, extending into the pelvic calyceal apparatus. But the tumor would definitely be within the renal parenchyma. In this case, the tumor was present predominantly within the calyceal apparatus, and that's why we give a possibility of a TCC or a urothelial cell carcinoma, and it was proven after the patient underwent surgery. Well, now let's talk about some of the important theoretical points about TCC of renal pelvis that you should remember. Now, TCC of renal pelvis is a relatively rare tumor and it accounts for only 5 to 10% of renal malignancies. If I ask you, what is more common, TCC of renal pelvis or TCC of ureters? TCC of renal pelvis is still more common than that of TCC of ureter. The most common site of TCC is urinary bladder, we all know that, and TCC of renal pelvis is 50 times less common as compared to TCC of urinary bladder. Talking about the age, it is a tumor of elderly patients. It is typically seen in patients who are more than 60 to 70 years of age, and it is more commonly seen in male patients. Talking about its associations, I hope all of you would remember from your previous knowledge that it is associated with a congenital anomaly of kidney. In fact, the most common congenital pathology of kidney, that is horseshoe kidneys, and it has also been linked with hereditary non-polyposis colon cancer gene. Let's talk about the radiological features on the ultrasound. We can get a mixed echogenicity mass lesion, which is filling the renal pelvis or the calyceal apparatus. It might show some color flow, but again, you cannot clearly stratify it as TCC or a clot on a ultrasound. So we can also see a thing which is called as oncocalyx on ultrasound, which refers to abnormal dilatation of a particular calyx because a tumor infiltrates and grows into it. On an IVP, as I just told you, it doesn't give much of an information, but if you combine CT with an excretory image, which is called a CTU or CT-IVP, then you can clearly make the diagnosis. The lesion is going to be seen as an intraluminal lesion, which is enhancing, which dilates the renal pelvis, which dilates the calyceal apparatus, and it typically is seen within the pelvic calyceal system rather than extending into the renal parenchyma. It may extend to the renal parenchyma, but the most important thing is renal shape and contour are preserved. And this is the reason why we call this type of a lesion as a bean type lesion rather than a ball type lesion. We've already talked about the classical stipple sign that we can see on a CT urography image or an IVP image, where the lesion which is present in the renal pelvis or the calyces and other parts of the urothelial system like the ureters and the urinary bladder is going to show up as a filling defect, but that's going to be heterogeneous, mottled in appearance. So this is another important sign which has been described with transitional cell carcinoma of the renal pelvis. Now, talking about the role of MRI. So, the role of MR urography is still limited, and we rely on CT scan only, along with the CT X-ray film for the diagnosis of renal TCC. So, now talking about the treatment. Treatment is predominantly surgery. We can do a nephrouretrectomy along with removal of a small part of the ureter, which is intravesical, up to the region of the UV junction. The other treatment that we can also offer is BCG. Now, we've been using BCG in intravesical route for bladder malignancies, but it can also be instilled in upper urinary tract in cases of TCC of the renal pelvis and can be an important alternate to surgery. Finally, one important thing that we need to remember is that these TCCs have a very high rate of recurrence. And it is said that once the patient develops a TCC of a renal pelvis, then there is a chance of almost 40% that he or she is going to develop TCC elsewhere in the urothelial system as well. So this is all about TCC of the renal pelvis and its radiological appearances.